You are, gentlemen. Welcome to the 2024 Public Health Challenge winners, World Tech Chart, and this is hosted by World Technology Partners. As you heard, Augustine S. Samolu. I'm the Dean for the College of Natural Sciences, Cottington University, Liberia. Just a little information about Cottington University. Cottington is a private university that is known to be one of the oldest universities in Africa. Basically, it was founded in 1889, so it has been there for a very long time. Well, before we dive into the presentation, let me provide a brief overview of World Technology Partners. World Technology Partners is an independent LLC headquartered outside Princeton, New Jersey, and is dedicated to promoting technology worldwide through various initiatives, and including the competition we're having today. Those are aimed at showcasing the work of students in technology and the sciences. Our director, you heard him previously, Paul Frank, has a master's degree from Brooklyn College, and he spent over 23 years in variety of posts at the National Geographic Society and NT Technology Council, ending up as an executive vice president before retiring in 2020. He is actually a visionary person who believes in technology and believes that research and technology can change the world if we work as a team. Today, we will explore four public health challenges and solution faced in various countries and discuss what presenters or students have brought forth, discuss their innovations and their solutions. Well, over the past months, we can count on basically 3 months. We've invited submissions from individuals and teams with significant experience in public health across various regions, including Africa, Asia, the Caribbean, Eastern Europe, the Middle East, and the Americas. Our esteemed selection committee, comprised of professional educators from diverse backgrounds, and many of them are from Bulgaria, India, Japan, Liberia, Pakistan, and the US. They've all reviewed these different submissions, and we were able to come up with winners. Submissions were actually evaluated based on the WHO and UN Sustainable Goals. The World Health Organization has identified basically 10 public health priorities for 2023. They basically include the health systems, mental health crisis, reproductive and sexual health, malnutrition and food security, diabetes, cancer, environmental pollution, substance abuse, infectious diseases, and climate change. Today, each presenter will have a 7-minute slot for their presentation, followed by a 3-minute question and answer. Questions will be addressed at the end of each presentation. We are honored today to have winners and panelists joining us, including the first presenter we expected to have, and that person is the third place winner, who is Sara Hassan. Now, Sara Hassan is known to be a 5th-year medical student at Cairo, Helwan University, basically in Cairo, Egypt. Well, during the COVID-19 pandemic, she took the opportunity to take multiple certified online courses from very accredited organizations, including Harvard Medical School, WHO, Incision Academy, and so much more. During her third year of medical school, she was awarded a scholarship for being amongst the top of her class. Ladies and gentlemen, I will now welcome Ms. Hassan for the first presentation for 7 minutes. You can just
Hi
give her a hand
everyone.
of applause. Thank you. Welcome.
Hi everyone. My name is Sara Hassan, and today I'll be talking to you about a major public health concern here in Egypt, namely diabetes. I'm just going to go ahead and share my screen. Today, I'd like to introduce you to Project NILE, an initiative designed to tackle the growing diabetes health crisis here in Egypt. The Nile River, which has long been a symbol of nourishment and life in our nation, inspires the project's name. Project NILE, which stands for Nurturing Individuals with Lifestyle Changes and Effective Management, aims to equip Egyptians with the proper education and tools required to effectively manage type 2 diabetes. According to a study done in 2022, Egypt ranks 9th in the prevalence of diabetes worldwide, with an estimated 15.2% of the population affected. The actual prevalence, though, is expected to be a lot higher because a staggering 40 to 50% of those with diabetes or prediabetes actually go undiagnosed. In Egypt, diabetes is the leading cause of many feared complications, including chronic kidney failure, blindness, amputation of the lower extremities, stroke, and acute coronary syndrome. That's where Project NILE comes in. Through a multifaceted approach, Project NILE has 3 core goals. First, we aim to identify the many Egyptians who are unaware they have diabetes or prediabetes. Early detection allows for timely intervention that can prevent the development of complications in those with diabetes, while also eliminating the need for lifelong medication in those with prediabetes. Our second goal is to delay the age at which type 2 diabetes typically occurs here in Egypt. Currently, it is widely acknowledged that type 2 diabetes is not just a disease of the adult, but it also occurs in children and adolescents. A study aimed at estimating the frequency of type 2 diabetes among diabetic young people in El Minya Governorate here in Egypt found that in a total of 210 patients under 18 years old, type 2 diabetes was present in 28 patients, or about 13.3% of the sample, which, when you think about it, is honestly quite catastrophic. Now, thankfully, this is still not the norm, and type 2 diabetes is diagnosed anywhere from 20 to 79 years old here in Egypt. But healthier lifestyles from a young age can reduce the development of diabetes altogether. Finally, Project NILE supports those diagnosed with diabetes with resources to effectively manage their condition and slow down its progression. More often than not, complications of type 2 diabetes may be the presenting symptom, and through effective management, diabetes progression can be slowed down, giving those affected with the condition a better quality of life for a longer period of time. To be able to address NILE's first goal, we need to find individuals at risk and increase detection rates. According to recent guidelines, obese or overweight individuals with additional risk factors should be screened immediately. Patients with prediabetes should be tested yearly. Women who are diagnosed with gestational diabetes should have lifelong testing at least every 3 years. And for all other non-overweight or obese patients, testing should begin at age 35 years. And if results are normal, testing should be repeated every 3 years. Now, Project NILE recognizes that not all Egyptians have access to quality healthcare and the means to get screened for diabetes. So it's important that we monitor with community-based organizations like schools, mosques, churches, and community centers to conduct mass screening and raise awareness about diabetes risk factors and preventive strategies. Community outreach programs and mobile healthcare units can reach all corners of Egypt, allowing us to reach more people, something that's similar to mobile blood donations. Technology is our ally in our fight against diabetes, with apps that are developed in Arabic, important for self-assessment of diabetes risk factors, that can also help Egyptians schedule appointments at nearby clinics for confirmatory testing and raise awareness about diabetes in general. SMS reminders sent from laboratories can allow for follow-up testing and educational messages as well. Because diabetes screening and treatment is pretty expensive, wider insurance coverage is needed to encourage more people to actually get tested and treated. Thorough pre-employment and preschool screening is especially important to identify vulnerable cases like children, where early intervention and management can save them from developing lifelong complications. Now, Project NILE actually has two arms: lifestyle changes and effective management, and it all starts with increasing awareness. We need to integrate diabetes prevention in school modules and encourage parents and teachers to participate in workshops and school events that can raise awareness about diabetes risk factors and preventive strategies. Social media and TV are now part of every household, and we need credible sources like doctors, nutritionists, and public health officials to talk about diabetes on highly watched programs and highly used applications. When it comes to lifestyle, two major contributors are diet and physical activity. And currently here in Egypt, most patients go to their physicians to get their medication prescription renewed and receive vague instructions like avoid sugar, eat healthy meals, and come back in a few months to get retested. These unclear and vague, unrealistic instructions need to be replaced with specific meal plans that are based on the traditional Egyptian cuisine and crafted by skilled nutritionists that work alongside the treating physician. The meal plans that are based on the traditional Egyptian cuisine don't alienate the treatment plans for those with diabetes from those around them, but rather promote healthier substitutions and alternatives that should be a part of every household. The traditional Egyptian cuisine is actually full of inherently healthy options like beans, lentils, and vegetables. Cooking shows can add 15-minute segments at the end of every showing, or even dedicate 1 or 2 episodes once or twice a week that promote healthier cooking demonstrations using readily available ingredients that make our traditional Egyptian cuisine more healthy and diabetes friendly. After all, in those jacked up oil prices, if you're still frying chicken and using them to do French fries, you're seriously missing out. The oven is a great alternative to still enjoy our healthy meals without needing to fry them or use any excess oil and make them unnecessarily unhealthy. Social media platforms can increase awareness by spreading recipes and educational content in Arabic to reach a wider audience, because healthy dietary changes shouldn't just be specific to those with diabetes and are actually very important in prevention and management of diabetes. Our second component is physical activity. And trust me, it doesn't have to look like heavy weightlifting at the gym. Easy, home-based, feasible follow-along workouts that are tailored to patients with their nutrition plans should be presented in brochures where illustrations can help individuals perform more exercise. Another way to approach physical activity is to integrate exercise into daily activities rather than keeping it as a separate element. And classic examples include parking your car about 10 minutes away from work or using the stairs whenever you can. And for companies where employees work for 8+ hours while they're sitting, providing the necessary environment to carry out some physical activity is crucial in the prevention and treatment of diabetes. Now, we can do this very easily by installing restrooms and cafeterias on a different floor and having cafeterias provide healthier meal alternatives. Now, trust me, you might think this is a punishment, but your body will thank me for it over the next few years. NILE's next goal is empowering management. Patients need to know when and how to measure their blood sugar levels and how to interpret results. This allows expensive resources like blood sugar monitoring strips, which are generally quite expensive, to be used wisely and minimize wasting. Remote patient monitoring is just like it sounds. It allows patients to monitor their conditions with physicians without needing to visit them in person, which is actually really important since most Egyptians live away from their treating physician. The way this works is that patients record their blood sugar measurements through wireless devices that are then sent to the physician in real time. And with more frequent measurements and realistic sugar monitoring measurements, like I said, physicians can craft better management options for their patients. It's also important to raise awareness and guidance on the adherence to medication. It's important that patients understand that diabetes is not just an acute condition like common cold, where taking medication just temporarily lowers blood glucose levels. Normal blood glucose levels are not an indication to discontinue treatment or lifestyle changes. Telemedicine shines as we need more communication and more awareness to manage those with diabetes or really any other conditions. And it allows patients who live, again, away from accessible healthcare or in really far areas to have one-on-one consultations with their physicians through online platforms where they discuss recent testing and medication adjustments without having to visit the physician in person. Remote coaching with dietitians, physicians, and fitness trainers is also possible thanks to the internet. So many classes can be hosted on Zoom or any other online platforms and can reach more people this way. The beauty of Project NILE is that it actually uses resources that we already have to craft feasible and better solutions for a lifelong public health concern. So we already have the skilled doctors, we already have the skilled nutritionists, we already have social media in virtually every household, and cooking shows are already being aired on TV. Through a few simple adjustments, Project NILE can also be applied to different areas where diabetes is a major public health concern. Culturally relevant solutions allow for earlier intervention, better management, and hopefully a better future for all Egyptians. Thank you so much for letting me tell you about Project NILE. I'll gladly accept any questions if you have any.
Well, thank you. Thank you very much to the audience. That was the presentation from Sarah Hassan. We now just give her a hand of the floor as we introduce or accept questions.
Thank you so much.
Thank you. Yes, so we will take now questions from the audience if we have any.
Yeah, first of all, can I ask a question?
Yes,
Yeah, sure.
please.
Great presentation, but as you said, screening for diabetes is a little bit expensive for most patients. Are there any other tests that can be more cost effective?
Yeah, so I actually think this is a great question. And through my research and studying, we've actually found out that currently to screen and diagnose and basically treat diabetes, we need to monitor patients through what is called the hemoglobin A1C testing. And I'm just going to briefly explain how this disease is done. So when we have high glucose in our blood, some of that glucose actually gets attached to the hemoglobin found in our red blood cells. And of course, if we have higher glucose, this means that more glucose attaches to the red blood cells, hemoglobin, and so we have a higher percentage of that hemoglobin attached to red blood cells. And because red blood cells have a half-life, or they stay in our bloodstream and have a half-life of about 90 to 120 days, hemoglobin A1C shows us how glycemic control has been over the past 3 to 4 months. So generally here in Egypt, it's performed every 3 months. There are other testing options that are present, and most similar is the fructosamine testing, which also detects the portion of proteins, but this time they're other than hemoglobin, that are attached to glucose molecules. The problem here, though, is that this test reflects glycemic control over the past 14 to 21 days. So it can be used to monitor any acute changes, and physicians usually use it if they have just introduced a new treatment regimen, or if they have just changed the dose, to check if that is actually working for the patient at the moment. Other tests include urine tests and fundoscopy, but in my opinion, these are mostly used in detecting diabetes complications rather than diagnosing diabetes itself, because you do need extensive follow-up testing afterwards. And our last option is using combined fasting blood sugar levels and the oral glucose tolerance test. But a study has found that these combined tests, when compared with hemoglobin A1C testing, hemoglobin A1C was actually more cost-effective and more accurate. So it makes sense to use hemoglobin A1C a bit more, especially since oral glucose tolerance tests are quite cumbersome to be performed by the patient. That being said, though, hemoglobin A1C does have its limitations, and those include that it can't be used in patients with anemia or red blood cell diseases, since this is the whole concept of the test. It also can't be used in pregnant women because their glucose levels are always changing. And the cutoff point in children is actually not yet quite known. So we can't diagnose type 2 diabetes with hemoglobin A1C in children. Another important fact where hemoglobin A1C falls short is that the cutoff point actually changes between different races. So studies have found that the race, for example, the African-American races tend to have higher cutoff values for the diagnosis of diabetes using hemoglobin A1C, which does raise the concern of universal guidelines being applied to all individuals the same way. So unless there's a clear contraindication, I think for the foreseeable future, hemoglobin A1C remains our test of choice. And while the test is slightly expensive, it is performed 4 times a year or twice yearly. And some labs do actually provide what is called a point system, where every time the patient gets tested, points get added to their, I guess, the number of times they've tested. And eventually they can redeem these points for any discounts or decrease or another testing later on in the future.
Sarah, final question very briefly as we how will your research aid people in very hard to reach centers or people who have limited resources?
Yeah, so like I said, I think that Project NILE uses resources that we already have and are widespread. But still, the fact that we have right now social media and telemedicine, this connects so many people that are found everywhere with their treating physicians. And I think we can definitely use that to our advantage. The fact that diabetes is a shared problem among all Egyptians makes it a very important incentive for all of us to participate in this. I mean, we're all part of the problem, but we're also all part of the solution. I've also mentioned that we can use mobile healthcare units like those that are used in blood donations to actually reach those hard areas to reach, or those who don't have access to healthcare. Another important aspect that we need to keep in mind is, like I said, most patients do come in for to renew their medication prescriptions or to receive any advice on healthcare or their recent meal plans or dietary changes. And I think these can definitely all be done through internet or through Zoom calls with the physician that can help reach those areas where healthcare isn't really feasible, or at least they have to travel long distances to reach their treating physicians. Social media has definitely helped us do that. The TV is part of every single household here in Egypt. We watch TV, and those highly watched programs can use part of their timing to actually raise awareness about this chronic condition.
Augustine, you need to unmute yourself.
Oh, I'm sorry. So I want to say hands of applause to you for your presentation. Congrats. Thanks for joining up and presenting.
Thank you so much.
Good. All other questions will be presented to you, maybe during our general discussion sessions. Well, moving forward to our next presenter, that's our second place winner. The second place winner for today's presentation is Abad Blackard. And Abba is actually a PhD candidate at University of Cape Town in South Africa. Abba, yes, I'll get to you. Let me just do a little presentation, introduction for you, Abba. Abad received her bachelor's degree in biomedical engineering from University of South Florida in 2021. During her time at USF, she had the opportunity to participate in a research project on power generation for rural areas when she traveled to Botswana. Her trip was a life-changing experience that led her to investigating universities in sub-Saharan Africa. One of her passions had always been improving access to healthcare, and she found the University of Cape Town's biomedical engineering program had published a lot of work in this area. To get funding, she worked with the Rotary International Global Grants Program, which funds postgraduate studies in their areas of service. She selected the Visual Clinic project at her isothesis as it addressed exactly the areas she was interested in working. And she had now graduated that master's project to a PhD project. We want to say at this time, welcome, Abba. The floor is yours for your presentation.
Thank you so much, Augustine. Share my screen. Can everyone see the presentation?
Yes.
Okay. Thanks. Thank you so much for the introduction. Today I'll be talking about my project, which is the design of a virtual clinic system for primary healthcare in remote, rural, and underserved areas. I'm a student in biomedical engineering at the University of Cape Town in South Africa. I think Sarah actually provided a wonderful introduction to my project, and she shared a lot about the value of telemedicine and virtual clinics and how they can be used in diabetes care. But to give a perspective, when we look at countries like the UK and those in Europe, we know that they have an average of around 5 doctors per 1,000 people, and the world average is around 2. But South Africa and Sub-Saharan Africa have well below these averages, with only 0.5 and 0.2 physicians per 1,000 people. And this lack of physicians has several negative effects on the healthcare system. This includes increased wait times for patients when they travel to the clinic. This also incurs increased costs for patients, as they have to pay for things like transportation if they have to go to the clinic multiple times, or lost wages or childcare, and also increased costs for health systems. And we also see a decrease in quality of care, as doctors have to move quickly between patients and don't often get to provide the best quality of care, as they're trying to treat so many people. So what we've proposed as a solution, or a potential solution, to help with the shortage of doctors in South Africa and in Sub-Saharan Africa, is virtual clinics. And in particular, we're looking at virtual clinics for remote, rural, and underserved areas. So those areas that have the least amount of doctors and the hardest time accessing medical services. You may be familiar with virtual clinics. Basically, they connect a patient to a provider in 2 different locations. There are a lot of instances of virtual clinics, but often when you try to implement these in the context that we're talking about, they are not successful. And it's because they don't consider the contextual challenges of these areas. So some of these challenges that we're talking about are things like power and access to power, access to internet. Some of the places that we work with have very limited internet access. Also things like digital literacy. So having users in these areas who can actually use digital systems. Some people may not have interacted with like a computer before, for example, and so it can be difficult for them to use virtual systems. And so my goal in this project is to develop a virtual clinic which accounts for all of these contextual challenges, to develop something that's actually feasible for these locations. And I do this through using a method called the user-centered design method. It basically does exactly what its name says. It centers the user during the whole design process. So that means involving the user during every step of the design process, so that your output is something that aligns with what users actually need. So during this project, I have attempted to build a virtual clinic system that would be used in, for example, a rural area. I'm targeting areas that have very small clinics, like a rural clinic. They may have some nurses or some community healthcare workers, some lower skilled health workers, but they have limited or no doctors. And so we try to connect these areas with an urban area, with doctors in urban areas, so that they can provide help with the diagnosis and treatment of patients in these areas. So how did we do this using the user-centered design process? We started by interviewing people within the healthcare system here in South Africa, and also people in digital health, to get an idea of what that space looked like in South Africa. Then we also did observations in rural clinics to get an idea of how these clinics function and what some of their challenges are, and then also reviewed literature that was relevant to this topic. And all of this information helped us come up with some requirements for our system that then helped us design our first prototype of a virtual clinic system. So this virtual clinic system included some different medical devices that allowed the doctor on the other side to actually get a better picture of the patient. So of course they have the traditional video call like we're doing right now, so the doctor can see the patient through the video call. But then we also have these two kind of specialized cameras. One is an otoscope, so it delivers a picture of the inside of the ear, nose, and throat for the doctor to see for the patient. And then also a dermoscope, which provides nice images of the skin. For example, if you have a skin lesion, the doctor can get a good quality look at that. And then we also have some vital signs that are being delivered to the doctor so they can see the patient's heart rate, blood pressure, pulse oxygen, temperature, respiration rate, and also their ECG. So this is good for any type of cardiac concerns, things like that. And then also not pictured, we have a glucose meter for tracking diabetes, which is another health concern here as well. And all of this interfaces through a web application. So the users are logging into a web application and then they're able to access the patient information and do an online consultation through this system. So again, in line with the user-centered design process, we came up with a solution, but we actually had to make sure that the solution worked and fulfilled the requirements that it was set out to fulfill. So how did we do this? We went into the field. We work with a rural area here in South Africa in the Northern Cape province. So we went here and we did some testing to see if our system would work on the internet connection that they have there. They have limited internet access. So we tried to provide services through this network access. And then we also consulted with some of the healthcare workers in this area, as well as some of the public healthcare workers around the university. And we just asked them to give feedback on how we could improve our system so that it will best integrate within the public healthcare system. And so now I'm in the process of taking these results and this feedback and trying to incorporate it into a new system that will hopefully, again, align up with what the users need within the settings that we're looking at. And the ultimate goal is for us to implement this virtual clinic system in remote, rural, and underserved areas in South Africa. And if this is successful, we'd also love to bring it to other countries and other areas that are in need. So that's basically what my project is. I want to say thank you so much to my university, the University of Cape Town, and my lab, the Telemedicine and Connected Care Research Group. I'd also like to say thank you to Rotary. Rotary International has funded me for my studies and also for the individual Rotary clubs that I work with for their continued support during my academic journey. And then finally, I'd like to thank the World Technology Partners for awarding me second place in this competition. Thank you so much.
Please give hand of applause to Abad for that splendid presentation. We will quick, Abba, thanks for the presentation. We quickly take questions from the audience. Yes, our first question from, we will encourage you to just introduce yourself prior to asking the question. Please do that. Yeah. Yes.
Abby, this is Paul. For some reason, your slides didn't progress
Oh, no.
during your presentation. So if you could send me a copy of it, we'll get it out to the people who were on the webinar. Okay.
Sure. Thanks.
Okay, so we'll take question. Paul, can you see the names? I'm not really seeing the names of who's supposed to be first.
No, they'll come in as, if they have questions, they can feel free to ask them at any time and introduce themselves and what country they're from.
Yes, I'm seeing 3 hands, and I want to take the first person.
Okay.
The couple there.
Sure. Let's go with Aga Hamza from Pakistan.
Thanks, Paul. Hi, Abby, and hi, everyone else. Hope you guys are all doing well. Thank you for that presentation. I do look forward to actually seeing the rest of the slides, so hopefully we'll get to them. I just wanted to ask something quickly. So the system that you're designing, is this focused on only providing clinical support to the patients, connecting them with doctors, or could this system also be used to provide remote trainings for new individuals who are in the field or they might want to upskill? Thank you.
Sure. Thank you so much for your question, Aga. That's a great point. So initially in designing this system, we were just looking at kind of improving the access to healthcare, and so connecting the doctors to nurses and things like that. But I think through that connection, there's definitely opportunity for training, especially when it comes to maybe using new or different types of medical devices. So in some of the consultation that we had with the nurses that we work with and the doctors that we work with, some of them feel like they would be comfortable in giving instructions, for example, to a nurse or a community health worker who isn't skilled in like using ultrasound, for example. Some of the doctors felt like they would be comfortable in kind of training the nurse on how to use that technology through a virtual communication. So I think there's definitely a possibility for that moving forward, and maybe a way to make the nurses and the other community health workers in these areas more self-sufficient and able to provide more services. So thanks.
Thank you.
Okay, let's go to Cliff Brock.
Thank you. Cliff and Mid Brock in Tarpon Springs, Florida. We're with Rotary. Great job, Abby. The question I have to ask is sustainability after this project ends and your projected source of funding downstream.
Well, that's a great question. So we try to not just work with health workers in South Africa, but also try to bring in government stakeholders and industry stakeholders. And so we hope that by involving them in the process as well, it's something that can become more sustainable as more students are interested in the project. And of course, I'm very interested in sticking with the project as well. So we hope that moving forward, we'll be able to keep the momentum of this project. Thank you.
Okay, Bon R. Are you there, Bon? Okay, let's move on. Ian Robertson.
Ian Robertson, Cape Town, South Africa. I'm a Rotarian. Great job, Abby. I'm interested in scalability and connectivity. I think your project is at a time when that's becoming very exciting. Would you like to comment on that, please?
Sure. Thanks. That's a great question, Ian. So actually in our research group, we focus on the networking aspects of our telemedicine solutions. I focus more on the biomedical engineering side, so I'm definitely not a network expert, but we try to incorporate new network technologies, things like 5G, into not just my solution, but our other telemedicine solutions as well. And so we look at a broad spectrum of things, working on in areas that maybe only have access to 3G networks, all the way to trying to implement 5G and possibly 6G solutions.
Thank you.
Okay, Gerald in Kenya.
Oh, thank you very much for this opportunity. I'm Gerald from Kenya. My question goes this way. Your project in design, in user-centered design of a virtual clinic system. So my question is, does it accommodate the cultural practices and patient patient privacy? Right.
That's a great question. So yes, a lot of the development in telemedicine is focused on patient safety and patient privacy, which is key in any area that you're working in with patient data. So we do try to implement systems that do consider this patient safety through a range of different cybersecurity methods. And then to the first question, talking about considering cultural aspects, I don't know if this kind of answers your question, but we do also consider language, which is part of a cultural aspect. So there are lots of different spoken languages in South Africa that are prevalent. So we do try to accommodate for these in a few different ways, depending on the areas that we implement in and that we work with. So yeah, to keep it short, I'll stay with that.
Okay, and final question from Joe Hobson.
Congrats, Abby, on your presentation. I'm Joe Hobson from Cape Town, also from Claremont Rotary. So Abby, I really like the way that the research is focused on the user and bringing the user along with you in the process. And I suppose this is linked to Gerald's question. I'm interested in the user's response. So, and the extent to which you have to manage that and help them shift to this new technology. So are they excited by it? Are they scared by it? Do they embrace it? Are the older generations finding it more difficult to do things virtually? Yeah, what is your experience of their response to that?
Thank you so much, Joe. It's a great question. So when we talk about users for my system, patients are important in the system, but we consult more with the nurses and the doctors because they're the ones that are interacting more with the system. And at first, I thought that actually the nurses would not be enthusiastic because I know that they're quite busy already and they're used to paper-based systems. And so I kind of had that anticipation going into our usability testing with the system. But I was actually surprised that when, at least the group that we did have come in, nurses who work in primary care in the public sector, I think they really saw the value of the time that a system like this could save for them and the ease that they could have in like transmitting data and saving patient data. So they were actually pretty excited, and even the nurses that I might say are not so digitally literate, like aren't as familiar with the computer. They would even say, I don't know the computer, I don't know how to do this stuff. But they would watch when you show them how to use the system, and then they would say, I would love to take computer classes if they're offered, because I think they see the value of like the end result. But it's definitely something that we have to keep considering every step of the way because user buy-in is one of the most important parts. So thank you. Thanks.
Okay, next presenter. This presenter is the Director's Discretionary Award. This was given to an individual who had a unique project, and that person is Fuen Ann. Quickly on her bio, Ann is currently pursuing her master's degree in food science at University of Malaysia Sabah. Her passion for research began during her undergraduate studies in food science and nutrition at the same university. She is particularly interested in exploring the health benefits of natural products. Today, we are honored to invite you, Ann, to this presentation. The floor is yours.
Thank you. So can all of you see my screen?
Yes, we can.
Okay, thank you. So hello everyone, my name is Fuen Ann, a master candidate in food science from Universiti Malaysia Sabah. Today I will be sharing my research on the cardioprotective potential of stingless bee honey in Sabah under the supervision of Prof. Dr. Chai Put Yi. So in our world today, we face significant challenges regarding hunger and food insecurity. The global population is expected to reach 8.5 billion by 2030 and 9.7 billion by 2050. Moreover, the COVID-19 pandemic has worsened hunger, affecting nearly 690 million people worldwide. To tackle this, we must explore an alternative food source such as seaweeds, plant-based protein, insects, and laboratory meats. Stingless bee honey falls under the category of insects product, which has been identified as future food. Moving to another critical concern, cardiovascular disease is a pressing issue, particularly in my country, Malaysia, and globally. In 2019, 18.6 million deaths worldwide were attributed to cardiovascular disease. Shockingly, in Malaysia, 1 in 5 adults have diabetes and 1 in 3 have hypertension, and half of the population is overweight or obese, all of which increase the risk of CVDs. And the healthcare cost in managing cardiovascular disease in Malaysia exceeds 9.65 billion ringgit Malaysia, which is a huge amount for the country. And now let's look into why stingless bee honey is gaining attention. Stingless bee honey presents significant opportunity. Meliponic culture or stingless beekeeping has gained traction due to its market value and health benefits. The global market size of stingless bee honey is around USD 7.84 billion, with Asia Pacific regions accounting for USD 2.73 billion. This honey have various health benefits, including antioxidants, wound healings, antimicrobial, and anti-inflammatory activity. However, there is still lack of comprehensive information on its anti-aging, hypolipidemics, and anti-diabetics properties. Therefore, exploring this aspect will lead to a new opportunities, especially when marketed scientifically to highlight its proven medicinal properties. Stingless bee can be categorized into 2 main genera, which is Melipona and Trigona. Within this species, Heterotrigona itama is the most common species bred in Malaysia to produce stingless bee honey. Stingless bees are very diverse, and with approximately 500 species being identified globally, and they live in tropical and subtropical regions around the world. On the left, you can see the picture of honey pots and bee bread, and on the right-hand side, it shows stingless bee honey from different botanical origins. As seen, different botanical origins of stingless bee honey have different color. Of course, the physical properties of it also different. And here are some pictures of stingless bee honey farming carried out in different countries such as Brazil, Philippines, Indonesia, and Malaysia. Despite the promising potential, stingless bee honey face several challenges in the market. Firstly, the production struggles to meet the high demand, resulting in a shortage of products in the market. Secondly, safety and quality concerns are prevalent due to various factors such as fermentation caused by high water activity and increased level of HMF due to dehumidification process, compromise the integrity and nutritional value of honey. Furthermore, the authenticity of stingless bee honey is often compromised by adulteration practice. Sugar syrup adulterations and deceptive labeling tactics undermine consumer trust and pose significant risks for both consumers and producers. These adulterations contributes to a broader issue of food frauds, with honey being one of the frequently targeted products. Addressing these challenges is essential to safeguard the value of the products in the market. It requires more efforts from producers, regulators, and consumers to ensure the transparency, authenticity, and quality throughout the production and distribution process. Therefore, to address the challenge, solutions must be implemented throughout the whole entire productions and distribution chain. Upstream solutions involve implementation of smart farming techniques with AI monitoring is foreseen as a solution in managing hive to prevent threats, monitoring bee health, and ensuring sustainable farming practice. Downstream, the focus shifts to effective processing, value propositions, and distribution, which involve the effort of establishing a certified processing center that ensure the quality and quantities of the products. In conclusion, my research actually aims to investigate the cardioprotective potential of stingless bee honey through in vitro and identify key phenolic compounds that are responsible for this effect. Additionally, we wish to evaluate the impacts of botanical and geographical origins on the cardioprotective potential of stingless bee honey. Furthermore, my study dived into the potential of stingless bee honey in addressing food insecurity and propose strategies to overcome existing challenges, thereby maximizing its benefit for societies. Through that objective, we aim to contribute to the understanding and utilization of stingless bee honey as a valuable resource with significant health and societal implications. So before I end the presentations, I would like to give a special thanks to the Ministry of Higher Education Malaysia for their financial support and Stingless Beekeeper Associations for their guidance throughout the study. And therefore, thank you very much for your time.
Thank you. Hand of applause to Ann for that presentation. Thank you. We quickly take questions. If we have, we will take questions now. So questions to time. If we have questions, if no question, then
Yeah, I don't see any questions here, Augustine.
I think okay. I think there is a question.
Well, yeah, there is one. I'm sorry. Gada Ramsey.
Hello.
Yes, go ahead.
Thank you, Tan, for your presentation, and thank you, Paul and Augustine and everyone for this great, all the great presentations today. I just wanted to ask Tan about other honey preparations or other types of honey. Do they still have a cardioprotective effect, or can they be used for their health benefits, or is it just the stingless bee honey? And thank you very much.
Okay, thank you, Gala, for your questions. So, of course, besides stingless bee honeys, others honey also shows somehow the same properties. However, there is still needs of further clinical studies that needs to directly compare the efficacy of the honey itself. But of course, for stingless bee honey itself, we are still doing further studies on it, and it was not confirmed yet. Of course, we open for a collaboration also to work together and for further confirmations of the for the potentials of cardioprotective effects.
Thank you. Okay.
Let's go to
Finally,
the next presentation.
yes, I think we're done. Hand of applause again to Anne for her presentation. We move directly to the next presenter or presenters. I think they will be presenting as the team. Well, our first place winner is the team of Christopher DeLuca and Jullia McGregor. They actually appear first from our panelists, from the judges. The committee concluded that they had the best work. They are actually master's candidates in Global Health System, Western University, London, in Canada. They're working on Seed for Change and harnessing the purification power of Moringa tea to improve water quality in Gweri County of Uganda. Briefly, I want to give a little bio for them. Hailing from Ontario, Canada, colleague Chris DeLuca and Jullia McGregor completed their undergraduate years at Western University and Queen's University, respectively. Both are now pursuing a master's in global health system through the Shinage School of Medicine and Dentistry at Western University in London, Canada. Adapted from their group's capstone project as part of their program, the two will be presenting their proposed core Seeds for Change, discussing the use of Moringa tea to provide water quality. As a culmination of their degree, their cohort will travel to Uganda next month for a few school and practical placements with local partners where they will participate or they anticipate their experiences and will provide valuable insight into the true viability and feasibility of their proposal. While the project is ongoing, there are other students who will provide expertise support to the team, and they include Elizabeth, Sia, Jen, Martian, and Mark, Debrat, and Kate Ramirez. Ladies and gentlemen, we now welcome to this stage our presenters who are known to be the first place winners and the last presenters. Welcome.
Jullia, we good to go? Well, thank you everybody for coming. It's nice to meet everybody. Thank you, Paul, for organizing, Augustine, for that awesome introduction, Sarah, Abby, and Tan for their great presentations, and to all who came out to the World Tech Partners Public Health Competition. My name is Chris, and alongside my partner, Jullia, we'll be presenting our idea, Seeds for Change, harnessing the water purification power of moringa seeds. Before jumping in, we wanted to give a quick shout out to our other group members who helped ideate this project proposal. So from left to right, beside me, that would be Elizabeth, Jana, Kate, and Kat, and our course coordinator, Dr. Nitin Mohan.
All right, thanks for that introduction, Chris. So before we dive into our proposal, we first need to look at what exactly is the problem and where it's located. So during the past 2 decades of economic growth, population increases, and intensifying urbanization, Uganda's water and sanitary services have further struggled to keep pace. And of the country's current estimated 45 million population, around 38 million people lack access to reliable and safely managed water sources. So based on the WHO UNICEF Joint Monitoring Program definition, this actually earns the country the ranking as the 4th worst country in the world for basic access to clean drinking water in under a 30-minute round trip. So looking at a closure scale of the issue, thousands of the individuals located in the Soroti district of Uganda, shown on the map here, are actually facing the worst of this water crisis, including the sub-county of Gweri, which we've chosen to focus on. And in a study conducted, participants in Eastern Uganda actually shown that there's limited knowledge of various methods that can be used to improve the quality of drinking water in this area. So combined with the fact that the water sources available to this population are considered very poor quality, there's an urgent need for sustainable and low-cost models for water quality treatment in the area.
So what is our solution? We plan to use moringa seeds to purify water. Moringa seeds come from the moringa plant, which is a fast-growing, sustainable, drought-resistant, and versatile plant. All parts of the plants can be used, but our solution focuses on the dried seeds. Next slide. As seen in this picture, the dried seeds are harvested as these brown shelled balls on the left, that once peeled can be ground into moringa powder, which is seen on the right. They're relatively small, and peeling requires just a little bit of pressure to crack the outside skin. Next slide. And this is how it works. So the powder of these seeds have dimeric, cationic, and water-soluble properties. What that all means is that they carry a positive charge. When the powder is added to natural water sources, that positive charge attracts contaminants such as clay, bacteria, other toxins, and essentially coats them to provide these larger clumps. This clumping together makes the sediment heavier and more dense. So over time, the clumps will fall to the bottom of the container. This frees up the top portion of the container with clean water. So all users need to do is slowly pour out the clean water while the sediment will remain at the bottom of the container.
So once we kind of found out the effects of moringa and saw the efficacy in its water purification properties, we sought to see if it had been used in similar settings before, and if so, what their findings were. So in our research, 2 key studies stood out to us that explored the use of moringa for household water purification in different contexts. So the first one was conducted in an area with polluted water sources in Nigeria, and found that treating water with moringa seeds significantly reduced not only turbidity, but also the presence of E. coli, coliforms, and other rotaviruses. And then the second study, carried out in Guinea-Bissau, focused more on the community engagement and perception of the use of the seeds for water purification. And it kind of addressed barriers to current purification methods and actually found positive outcomes and community satisfaction associated with the use of the seeds. And then in addition to these, we actually found that the seeds have been successfully used for water purification in various other African countries, with studies in Senegal, Sudan, and Ethiopia, suggesting their potential as an effective and accepted method. So in a study conducted in 2022 on Ugandans' willingness to pay for water infrastructure, it actually revealed that over 3/4 of households surveyed in the eastern region were unwilling to pay for water or large-scale infrastructure projects, predominantly due to socioeconomic factors. And it's kind of highlighted the need for an inexpensive or externally funded solution. And in past studies, community uptake was high due to the familiarity with Moringa and its easy implementation. So in Uganda, although Moringa is actually grown locally, the main barrier throughout our kind of research that we noticed was the potential for water purification was the lack of knowledge on how to actually use it. So through our proposal, we kind of aim to bridge this gap in using education, which we propose to achieve with strong partnerships with local organizations, including Tacoma listed here. And this way, the project will be able to kind of leverage this local knowledge and relationships and credibility within the communities to facilitate development and implementation.
Awesome. So these are the proposed impacts that we thought with that comes with our innovation. We framed our proposed impacts by using the 2015 UN Sustainable Development Goals. We realized that with our innovation, we can better SDG 6, which is clean water and sanitation, as we would create more sources of clean drinking water. And we would also strengthen participation of local communities, as this would be a technique that they can use with relatively little training and is very sustainable to be used in the future. We also felt that our innovation would fall under improvements to SDG 3, which is good health and well-being, as will reduce the incidence of waterborne diseases, particularly diarrheal diseases, which in turn reduces mortality and susceptibility to getting sick. As you can see by our statistic there, we hope to lower DALYs, or disability adjusted life years, per 1,000 children under the age of 5. To explain that a little bit more, DALYs are a measure of disease burden that says how many years of life are lost due to ill health, disability, or early death. In our case, our solution plans to reduce the impact of disease and premature death. So we hope to reduce that number of DALYs, particularly in young children as well.
And lastly, kind of in addition to these direct impacts that Chris mentioned, there are many additional indirect impacts that fall under other SDGs and their targets that we anticipate. So for example, looking at target 5.1, we hope by that providing cleaner and more attainable water sources, women and girls will have to spend less time retrieving household water, and the saved time can then allow them to fulfill other productive activities, including attending school or work. Another notable impact is the bettering of Moringa production and sustainability through the generation of small-scale industries and the economy falling under SDG 8. So in summary, our objective aims to increase the accessibility of clean water for rural regions by conducting the small-scale project in the Gweri sub-county of Uganda, and we aim to do this one seed at a time. So thank you for your attention, and we'll turn it back to you, Augustine.
Well, thank you. Thank you. A hand of applause again for our first place winners. And thanks a lot for presenting, telling us what your project is. We will quickly go on to take questions from our attendees. So we have the first question coming up.
That would be Ian Robertson.
Good.
Ian, you need to unmute yourself.
Yeah, I know. I figured it out. This thing is very complicated. I'm very interested to know how much water is used in the creation of the seed. And that'd be very interesting to know that. And then I'm also interested to know, is the purification complete, or does it just reduce the level of infections, or how effective is the filter in eliminating the diseases, the E. coli diseases that we're very concerned about? Thank you.
Awesome. Thank you for that question. Well, we don't have exact numbers about how much water it takes to grow. We did realize that this is a very versatile plant, and that it can grow in sort of drought endemic regions, leading it to be a little bit more of a sustainable implementation. And amongst farmers growing their other crops, we thought that this could be transitioned in or replaced. And to your point regarding whether or not the purification process is done, what Moringa seeds
touch on that, Chris, if you want. That's kind of my area of the project. But if you kind of remember back to one of the slides that we actually did include, there has been many studies done kind of looking at the efficacy of the seeds, but specifically in areas like this, the Nigerian study that we focused on in our presentation actually showed an over a 99% efficacy in removing E. coli and other coliforms, as well as reducing the turbidity. And this was without an additional filter. So this was simply just putting the seeds in. Other kind of people that have looked at implementing this have also looked at distributing filters along with, so that they could directly use that in tandem with the seeds. And that all, even kind of like in the Nigerian one anyways, implementation kind of just enhanced the effect. So it was, I think without was 99.16 and with was just over 99.7. So it's, even without those kind of additional measures, it's still very effective in and of itself to kind of combat the presence of those.
That's very interesting. Thank you.
Okay, are there any other questions? Here's one. Gerald. Gerald, go ahead.
Thank you very much to our presenters. My question is, can the Moringa seeds be prepared locally at home? And if yes, is that preparation at home, will it be enough to be effective to purify the waters? Thank you.
Yeah. From our research, we found that all it takes is just drying the plants, and then you can harvest the seeds. And we found that roughly 1 to 2 seeds ground up will filter about 1 liter of water. So given in our picture of the plant, there's plenty of seeds in one like leaf of the plant. So it does seem pretty feasible for us that it would last quite a while for families. Even if they went to go purchase the seeds, they would have a long shelf life because they're dried as well, and can be used for months in advance.
Yeah, and I think kind of expanding on that too, something that we are kind of seeking more insight on when we actually travel to Uganda is looking at the sustainability of growing the seeds. So something we considered was actually looking for the funding and then distributing plants to households, and if that might be a better kind of avenue as opposed to partnering with farmers and doing it that way. So it's something kind of that we're looking into and seeing which one might be the more sustainable option there.
Okay, great. Mustafa, you had a question?
Yeah, first of all, thanks, and it was a great presentation. And I have 2 questions. Is the water ready to drink after being mixed with the seeds, or are there more steps to go, like filtering the water again or something? And how long does it take until the sediment is formed in the water?
Start with that one, Julia.
Yeah, you can start off. So the sediment actually starts forming within the first hour. However, most of the studies that we kind of looked at indicated letting the water sit for at least, I believe it was 3 to 4 hours, kind of to get the optimal amount of sedimentation. And then it is important to note, and something that we really thought that will need to be stressed in any education pursuant to this, is really kind of balancing letting water sit, because as many of us on this call know, I'm sure know, the water sitting there then poses other challenges into things like breeding habitats for mosquitoes and things like that, that can then further contaminate it and cause issues from it sitting there. So kind of finding that sweet spot, but typically within a few hours is kind of when it's at maximum efficacy.
Yeah, thanks a lot.
Okay. Our final question for the day, Hada Ramsey.
Thank you very much for giving me the opportunity to ask. And thank you, Christopher and Julia, for the great presentation and the great idea. Actually, I think locally grown seeds can be a great solution to purifying water in a lot of countries. But I wanted to ask, does the taste of the water change when you add the moringa seeds? And does it have any other side effects? Like, can one get used to it, or can it cause other side effects?
Yeah, I can take the beginning of this one as well, Chris. So the kind of something we did to kind of test it, as well as we actually did our own little experiment in London. So we actually did drink the water with the moringa seeds in it. And we also had colleagues in our group. One of our colleagues is from Ghana, and she had tried this method before. But personally, we actually didn't find any taste difference. And in the studies that conducted and kind of looked at the community acceptance, that was never really a deterrent of the taste. As for side effects, there hasn't been any real side effects to using it as a purification method. Simply eating and taking moringa supplementations, because moringa leaves and things like that are harvested for supplementation purposes. Typically, the only really side effects or things like that are kind of contraindications for pregnant populations, but we hadn't really seen that kind of replicated in looking at it for a water purification source and looking at the seeds. It was more of other parts of the plants, but I definitely think that might be an avenue going forward to look at and see if there are any that developed, but we didn't come across anything in our own research.
Thank you.
Okay, so final question. My concern is drawn to the time people would take to have these moringa prepared and have it used. Is it expected to be used for continuously? Can they have it placed into a well, for example, because people draw water from the well or the pump, and can that kill just the bacteria and they will no longer have to place it there? Do they have to use it continuously, like every time?
From our experiment and like speaking practically, we figured that a lot of the time you would have to let the water sit, as Julia mentioned. So maybe having those communal sort of wells or communal bins for the water might not be ideal. So it would be a little bit more of an individual implementation. But yeah, Julia, you wanted to add on to that.
Yeah, I think that's a great question, Augustine, and something that I don't think we really came across in our research, because I simply don't think it's been done to actually put the seeds into a bigger water source. It's mostly just looked at households. And I think that also has to do kind of with the cultural aspect as well, because currently, especially in these rural areas, there's not as much as an emphasis on water purification methods if they are used at a community scale. It's mostly water is obtained, and then at home you kind of go about the different ways that people might, if they have access to boiling water, if they have access to adding bleach, things like that. So I think in looking at the actual implementation as well, household is just something that has been done in the past, and that potentially might be more feasible than looking at trying to do something at a community level.
Okay, I think we're done with questions. Hand of applause to our presenters, please. Good. Today, I want to inform you that we have people in attendance from Egypt, South Africa, Canada, Malaysia, of course, Liberia, Australia, Belgium, Brazil. Yes, we have many people from Egypt, of course. I want to be glad that you've put up the time. If someone is from Germany, another person from Greece, someone is from Haiti, India, Kenya, New Zealand, Nigeria, Pakistan, Taiwan, Uganda, Ukraine, United States, Zimbabwe. So we are glad to have all of you. Next, we go directly to our general discussions. This time, We encourage an interactive discussion focusing on either the previous presentation or the 10 global public health priorities, which were identified in 2023. We welcome questions from the attendees. We also invite you to share your perspective and insights on those different challenges you may have had over the time doing your research. So this is general. We can speak shortly, and we have this entire discussion closing up, announcing again our winners and telling you where we're going after this presentation.
Okay, this is Paul. If there are any questions, please feel free to put them in the queue, and we'll keep it open for a few minutes. I think that's it, Augustine. Oh, here's one. Hada Ramsey. Hada, are you
Sorry,
there?
my microphone was off. Sorry. Thank you for giving me the opportunity again. I wanted to ask Sarah Hassan. I'm not sure if this question is a bit off topic, but I wanted to ask her if oral hypoglycemic drugs are safe to use for pregnant women, and if they are safe, can we use them from the beginning of the pregnancy, or do we have to wait until a little bit more on into the pregnancy, like from the second half of the pregnancy or something? If she can help me on that, thank you very much.
Yeah, sure. So I think this is a great question. And honestly, at this point, I don't think I can make any straight claims as to what is safe for those who are pregnant, since those are a very delicate part of the population at this stage. However, I would say that usually in stressful conditions like pregnancy or heart diseases or a hypertensive crises, or, basically vulnerable times, we do recommend insulin as our first line choice. So unless medications are clearly stated to be safe for pregnancy, they're usually given. We do like to avoid any susceptible medications or anything we suspect in the first trimester because of course, the all or none effect. And I think it's really important to spread awareness around this point as well, that medications given in the first trimester don't necessarily have to cause abortion, but they can just pass unnoticed. I think we should definitely go back to the specific criteria of medication itself, since oral medications come in so many different categories. There's metformin, there are sodium glucose transporter inhibitors, there are gut hormone analogs, there's obviously insulin. So each of those definitely has its advantages and disadvantages, and we need to consult the medication brochure as well as the gynecologist that is currently following up with the pregnant woman to make sure that the correct medication is being prescribed. So because oral hypoglycemics don't just come in one category, and there are several different categories under that a very broad title, and because pregnant women are a vulnerable part of the population, I can't generalize and tell you that oral hypoglycemics are all safe or they're not all safe. But what I can say is we need to check the medication criteria itself very carefully before prescribing these medications for pregnant women.
Thank you.
Thank you.
Any other questions from anyone? Okay, Ian.
I couldn't find out where to type the question. That's how old I am. I'm wondering with the seeds whether the flocculant can be recycled, whether you can't get a further advantage from the material, whether a drying sterilization process wouldn't work.
Well, considering the properties of the seeds sort of bind on to the toxins of bacteria, we didn't figure it would be sort of ideal to prioritize recycling it. And furthermore, just based on how cheap it is and how accessible the seeds are once they're dried. We didn't really explore any opportunities into recycling, but that's a great point and something that we could definitely look into for further implementation.
Thank you.
Thank you.
I had a question for Tan, actually. While she was speaking, I kept thinking about the Africanized bees. And I didn't completely understand. I understand these bees can't sting you. Are the stings removed? Is that why you're focusing on this type of bee? Tan?
I'm sorry, can you repeat it?
I'm not an expert on bees, but I understand that because they aren't able to sting you, you're able to take more advantage of them. Is that correct?
Not really, but basically it's due to stingless bee honey is one of the product in the state where I study, which is Sabah. So I wish that through this product is a product that been sold as a premium product actually in my country. But however, people often actually didn't really care about the quality, which everyone know. Honey is actually a food that been one of the top 10 food that have been food fronts worldwide. So same here, actually many people doubt on the authenticity and also are all the medicinal properties claimed by all the farmer, seller, is it real or not? That is why I dive into the interest to know more about this stingless bee honey in my own country. And I hope that through this study, I actually can help the farmer here to actually have a proper way to sell their products and also have a proper marketing way instead of just self-claiming, but they can have an evidence-based claiming in future. Yeah.
Very interesting. Thank you.
Thank you.
Well, thank you. If no questions coming forth, we want to again announce. Okay, there is a question there.
Yes, Gerard.
Yeah.
Gerald.
Okay, thank you for this opportunity. My question to Anne. Okay, I'm requesting to know the features of the stingless bee. How can one identify that this is a stingless bee? Yes, you can help. Thank you.
Sorry. Can you repeat again your question, because I think my line a bit not really strong.
Oh, sorry. My question is how can one identify that this is a stingless bee, or how can I differentiate between the two? Stingless, the one that stings one.
Okay. Allow me to rephrase the question. Is it what you mean is how can you recognize whether this honey is a stingless bee honey or from a normal honey bee?
Yes, right.
Good question.
Okay. So basically, for your information, normal honey from normal bee and also stingless bee honey is different. Stingless bee honey possesses a sour taste it's slightly more sour than normal honey. And at the same time, it's actually the water activity is higher, which means it's more liquidized compared to a normal honey.
Okay.
Yeah, Gerald.
Okay.
Gerald, you still there?
Yes. Thank you once again. I would request my sister Anne, if you comfortable share the full information about the bees, the stingless bee honey, if you don't mind. Yes, fine. Thank
you. Information.
Okay. So,
you mean You mean you wish to know like the details, nutrition information on the stingless bee honey?
Yeah, sure.
For now, I think I could not give you a very, how to say, a very proper or standard answer. But if you wish to know, maybe you can actually email me and I can leave my emails to you. Is that okay?
Okay, so we expected to have the work on the website, and Jera can just, if you have 2 minutes, things with.
Okay. Yeah, I think they can. We'll set up an email for you all to communicate with. Malik, you had a question. Malik, are you there? Oh wait, I'm sorry. Okay. Okay. Mustafa, you had another question?
Yeah, I'm sorry. I just wanted to ask Sarah Hassan, since I'm a medical student as well. Does your project aim to decrease the prevalence of diabetes? Because I know there are other factors involved, like genetics. So how does your project plan on dealing with genetics and other factors that may cause diabetes?
So Project NILE basically aims to target those modifiable risk factors. We can't really change the genetic makeup of an individual, but I think it's really important to note that the environmental factors play a very important role in the end result of a disease or a process going on. So effective diet, physical activity, proper management, these are all factors that also work with genetics in the expression of the disease. So that's the genetic side. When it comes to prevalence, diabetes is a chronic condition, right? And in chronic conditions, prevalence tends to exceed incidence. And this is because once you're diagnosed with diabetes, they enter that prevalence pool for as long as they live. So if our project works well and more people get diagnosed with diabetes, I expect the prevalence to actually increase and not decrease, at least for the foreseeable future, just because more cases, as I said, there are about 40 to 50% of undiagnosed cases here in Egypt. And so if we diagnose these cases, they raise the incidence and the prevalence levels as well. So as I said, right now, the prevalence is about 15.2%. And as more people are diagnosed, this prevalence is expected to go higher and is already expected to be higher than it is because a lot of people are undiagnosed. So for the foreseeable future, we expect the incidence and prevalence of diabetes to increase actually because more cases are being diagnosed and a lot more cases are being added to that prevalence pool and actually have diabetes.
Okay, thank you, Sarah.
Thank you.
Our final question today is from Haza Ramzi.
Yes, thank you again. Tan, my question is for you, please. I wanted to know if this honey that you're talking about is available for anyone to buy, and if the price is like within reach, and if there's like a certain amount that should be taken, not less than something, and if we should not increase above a certain amount. Can you please clarify these points? Thank you very much.
Okay, thanks, Gala, for your questions. So for this stingless bee honey at my country, the price is actually around 200 ml. So it's around 100 ringgit Malaysia, which is actually quite high compared to other type of honey in Malaysia or in the world itself. And yeah, of course, for your questions about the dosage or how much we should consume, this is actually part of my study, which I'm still searching for the answer as well. And at the same time, I'm actually very interesting to know also like how much is the dosage people should consume without, overtaking these products. Yeah. So I hope that in future, if really I get to find the answer, I will let you know. Yeah. Thank you.
Thank you very much.
I think that was our final question. We want to take this time to congratulate again Sara Emad from Egypt, Abad Blackard from South Africa, Jullia McGregor, Christopher Token from Canada, or DeLuca from Canada. From Malaysia, these different submissions we're going to be having. We go on to have this climaxing to the end. In conclusion, identifying and addressing those major health challenges, we know they are factors for achieving universal health care targeting. Yes, Paul, you wanted to say something?
No, I'm sorry, I'm coughing.
Oh, okay. So I want to say those different health challenges are vital for achieving universal healthcare targets by 2030. That's our goal. Collaborations, cooperations, and global efforts are crucial to overcome these challenges effectively and sustainably. This was our first major effort in the life sciences and public health, and we hope to expand these efforts, especially in public health in the future. During the summer and fall, these award winners will be contacted and will have a second opportunity to share their projects with government and non-profit leaders in respective regions. Thank you for joining us today. We look forward to insightful discussions and meaningful exchanges. Please be informed that our next competition is focusing on green sustainability showcase. This is very similar to the public health competition we've had, but in addition, we are seeking submissions, basically focusing on organic architecture. Following up on the work of Frank Lloyd Wright, who was experiencing or experimenting with the concept of approximately 100 years ago. Deadline for all submissions is known to be May 7. Information on submitting is also on our website. You can check the website if you don't have it or you don't know, worldtechnologypartners.net. May you all have a wonderful day. Thank you again for coming. We hope to communicate with you in the soonest possible time.
Thank you again.
Thank you, Paul and Augustine, and congrats to all the winners.
Thank you to Paul and Augustine for inviting me over, and a big thank you to those who attended. Hopefully you got something out of this webinar. Thank you.
Thanks, everybody.
Thank you all.